Evening. Welcome to today's webinar, Unpacking Depression, Personal Experience and Clinical Insights. Depression is a word that we use in common parlance. Everyone talks about being depressed. People talk about all kinds of things, being blue. And when is this, when is it just normal, I guess, reaction to everyday life? And when is it something that we should pay more attention to? This webinar is sponsored by JOMA. JOMA is the Jewish Orthodox Women's Medical Association, which is an organization of 600 plus female physicians spanning the spectrum, but essentially in the Orthodox Jewish life. We have been sponsoring webinars and presentations and trying to educate each other as well as the community at large. I'm the moderator for tonight's experience, and so the goal is to spend about 10-15 minutes hearing from Jessica, and then another 10-15 minutes hearing from Dr. Shayani, and then we will open up the panel to questions, and which you can put in the text box, and hopefully there will be both an educational and maybe even an inspiring experience. So without further ado, Jessica.
Hi. Thank you so much for having me. Sorry, I was having difficulty changing my name on the screen. So I am here to share my journey about struggling with depression. And just to give a brief history, I've struggled with anxiety basically my entire life since I was very, very young. And then 7 years ago, I was introduced to depression. I've been running an at-home daycare. I work with 2-year-olds. I've been doing it for 15 years. And 7 years ago, we finally bought our first house. And I'm not a legal daycare, meaning parents are happy, kids are happy, but it wasn't legal. And somebody complained. And the state showed up during dismissal over the summer while I was running camp. My body at that moment went into like a freeze response. I totally froze. I couldn't move. I remember one of the parents came in and literally walked me from the outside. We were doing dismissal into my house and continued the rest of dismissal. The next day, I started doing everything that I possibly could to become legal, taking all the legal steps, all the documents, whatever I was supposed to do to become legal so I could continue my job. While I was doing that, my body started going through what now I know was a trauma response. And I was unable to eat for over a month and a half. I lost probably 30 pounds. I couldn't swallow. I had a lot of physical symptoms that were causing me to just not feel well. And that spiraled into severe panic attacks. Hatzalah was at my house, I would say daily for about 2 weeks until I finally ended up in the ER. And these constant panic attacks led me into, for me, what was my first introduction to depression. Every person that goes on their journey has a different, experience of what either anxiety or depression feels like to them. And for me, 7 years ago from what it feels like now, and I still continue to struggle, it kind of changes as things happen. The best way for me to describe what depression, and it's going to be hard, it's really hard to put into words because it's a very intense emotional pain that eats away at your insides. It makes it very physically hard to get out of bed, to do basic tasks like showering or making my kids dinner. I mean, I showed up at work as best as I could. I run a children's and women's gemach. I tried to do that as best as I could. But every single step was like carrying weights and bricks on my shoulders. And the depression got worse for me, and it started coming out in self-harming behaviors, which was very new. I never experienced that, with my years and years of anxiety, and a lot of intense suicidality. The pain became so intense that getting up every day and having the desire to keep moving forward with the pain was getting harder and harder. I was already on medication for years for my anxiety, again, never for depression. Everything had to be reevaluated, new medications, which had its side effects, takes time to get through the process. I went from being in a hospital to doing exposure therapy for panic, to going to DBT, to ending up hospitalized twice and to a rehab. And today, 7 years later, I run a mental health organization that I started because I needed support for living with a mental illness, and I couldn't find it anywhere out there in the world. To be honest, over the past few days, my depression has actually climaxed higher and higher. When my panic goes into a downward spiral, my depression creeps in. And if I can't get the panic under control, the depression gets worse and worse and worse. I think one of the hardest and most challenging parts for me living with depression is that very often I can push through it and appear to the world that everything is okay. I can show up at my job. I can greet 2-year-olds at the door with a smile and parents with a smile. I can run a gamach. I can parent my children as best as I can, yet I'm living with this internal invisible pain that really is destroying my mind and very often plays tricks on my mind. And so for me, and it's hard to do when I'm feeling depressed because my brain tells me to isolate and to back away because my brain tells me my illness can be a burden on others, when really what I need the most is connection and support and whoever I can to rally around me. But it takes out to others for help. And that's also really, really hard. And I never like to tell people, that I've gotten to the other side of anxiety. I've gotten to the other side of depression because I personally, at least for my situation, don't always believe that there's another side, but I believe that there's a path through. And sometimes that path through can be lighter and sometimes it can be darker, and gain the skills and the tools, which isn't easy. It's a lot of work. It can be therapy combined with medication, combined with support groups that make that tunnel a little bit lighter. And each time I feel, like a phase or a spout of depression coming on, I learn as I go what works for me, what doesn't work for me. And I definitely, as I'm sharing, whoever's on here listening that's struggling, my heart is definitely out there with you because it's a really, really hard journey. I hear many times, and unfortunately, sometimes I relate to the fact that if people could just see how hard it was to get through our days living with this illness, we would get more support. Unfortunately, for many of us, it is invisible. And so that's why I hope to help others be a voice to express what it's like to live with a mental illness and really be a voice to others to gain and put more support within communities for people that are struggling, and just continue to show up and be vulnerable and share and be courageous. And that's my journey so far.
Jessica, thank you so much for sharing what is clearly what's been an excruciating experience for you, but that one that you have been able to learn from and manage and push through, even though it's not true for everybody, but even though your experience has become a repeated illness, if not chronic, but still
Correct.
all your ability to manage it and your ability to handle it and your lessons you learn from it and the courage to get through it and to share is really admirable. Just a little housekeeping. The chat box is disabled, but please post your questions to the Q&A box. The questions' identities will not be seen by the rest of the audience, but please feel free to do that. So I'd like to turn over the webinar to Dr. Shayani, who is going to talk about the psychiatric, she is a psychiatrist affiliated with Cambridge Health Systems and Harvard Medical School. And she has a private practice in Boston. And she's going to talk to us a little bit inform us and educate us a little bit about the psychiatric aspect of depression and depression care. Dr.
May I interrupt for just one moment? I want to be very clear. You have the option when submitting a Q&A question to have it be anonymous. If it is submitted anonymously, then the name will not be seen when the question is answered. If it is not submitted anonymously, the name may be seen when the question is answered. So if you do not want it seen, you need to click the anonymous box if you do not want your name seen.
Hi, good evening, everyone. Can you see my slides?
Yes, perfect.
First of all, Jessica, thank you so much. That was really powerful to hear about your personal experience. It's a really vulnerable place to be in to share all of that information. And I think it's really commendable because I think people going through it need to know that there's a community out there who's experiencing the same things. Thank you to Joma for having me here, Dr. Mermelstein and Aliza for organizing, and Dr. Weinberger. Doctor later, I think, because he just started residency. So today I'm going to talk about depression. I'm going to give a little bit more clinical information, share some data about depression. I can't do a better job than Jessica, who really gave us more of a personal insight, but I'll try my best to give some information to everyone. I'm a child, adolescent, and adult psychiatrist, so I've seen depression across the life spectrum. And today we'll be taking a closer look at what that looks like. Depression is really a complex condition, like it's been said before. It goes beyond just feeling sad. It can affect many parts of life in deep and lasting ways, but it's also treatable. So today I want to kind of unravel some of the myths about depression. And I also want to be clear, though, that what I talk about today shouldn't be taken as clinical advice. If you have personal questions or know someone struggling, I want you to reach out to a healthcare provider, but I am happy to answer questions that come up in a more general sense. So these are a little bit more data about depression. It's startling to know that the number of Americans aged 12 and up is 1 in 8, which is actually double what it was a decade ago. It affects both youth and adults significantly. And the World Health Organization identifies depression as a leading cause of disability worldwide. And we'll get more into that later. I know Jessica's sharing that she can still function in some capacities, but there's a lot of functional impairment from depression. It's also among the most treatable of mental health disorders. Between 70 and 90% of people with depression respond well to treatment. But in that light, only 50% of people who do have depression get treatment. So we need to understand what are some of these barriers to treatment. Today, my goal is multifaceted. I want to equip everyone with tools to recognize depression, differentiate it from ups and downs of everyday life, and from the natural process also of grieving, which is really a different experience, even though they share some similarities. I want to debunk a lot of misconceptions about depression and also discuss some of the causes of depression and evidence-based treatment options. At the end of our time together, I really hope everyone feels more empowered, informed, and ready to engage in meaningful conversations about depression, mental health, and where to get treatment. So here's a quick look at our, here's a quick look at our agenda. We're going to start by exploring depression symptoms, move on to fact versus fiction about the common myths and debunking them related to depression. And then we'll discuss various causes of depression, and then we'll dive into available treatment options. So what does depression feel like? Depression affects more than just your mood. It shows up in 3 key ways: emotional, physical, and cognitive. Symptoms also last for weeks to months, and they interfere with daily life. So they may not interfere with every capacity. Maybe you can work, but it's hard in home. So there's functional impairment maybe in many areas, maybe in one area. Emotionally, people, and I can't do a better job than Jessica, who really shared personal experience, but just an overview is that emotionally people feel sad, hopeless, or empty. There's a deep sense of disconnection, and even things that they used to enjoy, they don't bring them joy any longer. Physically, depression can cause big changes in sleep, like insomnia, oversleeping. There might be appetite or weight changes. Individuals might experience loss of energy, feeling drained even after they've rested a lot. And some people even might move more slowly, or on the other end of the spectrum, people might be more restless. Cognitively, it gets harder to focus, remember things, make decisions. A lot of people may experience harsh self-criticism or feel worthless. In more severe cases, depression can lead to thoughts of self-harm, death, or suicide. Research shows that anywhere from 1/3 to 1/2 of people with depression might have suicidal thoughts. This is obviously a very sensitive topic. And while any amount of this dangerous risk is scary, it is also important to understand that having these thoughts doesn't mean someone will act on them. And there's a big difference between acting on suicide and having plans to act on it and thinking about it and thinking about not wanting to be alive as an escape from pain. But really what we know is that suicidal ideation indicates a deep suffering and a need for support. And with the right support and treatment, people can recover and the risk of suicide is greatly reduced. Another thing I like to emphasize is that depression looks different across the life spectrum. In children, you might see irritability, clinginess, behavioral issues rather than overt sadness. For teenagers, it might look like withdrawing from friends and activities, a decline in school performance, or increased anger and issues at home. And for adults, they might experience more of what we talked about typically tonight with energy changes, hopelessness, fatigue. And in elderly individuals, it also might look more like a medical condition, a memory problem, a physical complaint that might be mistakenly attributed to aging, but really is an emotional and a depressive disorder. So recognizing these differences is really important. Another thing to recognize is that depression is very different from sadness and grief. Sadness is a natural, temporary feeling triggered by everyday setbacks, or maybe sometimes not triggered by a movie, triggered by something transient, and it doesn't disrupt daily life, and it's a healthy emotion. Grief also is a natural response to a significant loss, losing a loved one or other losses that are significant, and it's painful, intensely painful, but it eases over weeks to months. Sometimes grief can include thoughts of wanting to be with the dead or thoughts of wanting to not be alive because they want to be with the person they lost, but it's different from suicidal thoughts in depression where there's more of a worthlessness. And then, like we said, depression is persistent. It lasts for a long time. It can recur. It affects daily functioning. It could emerge from sadness or grief that kind of doesn't go away. So it's not that sadness and grief never lead to depression, but they don't always lead to depression. And also important to know that grief sometimes can evolve into depression if it's lasting a long time. If thoughts become more dangerous, then it would be depression, and depression requires professional care. Myths about depression that we'll debunk. So this could take a long time to go through, so I'll be brief and we can talk more about it in our Q&A. But first, depression, people can't just snap out of it. It's a medical condition. It affects brain chemistry and mood regulation. It's not a sign of weakness. It's not related to willpower. Studies show that professional treatment, like we said, really improves outcomes. Depression, number two, is treatable and not permanent. 70 to 90% of people, like we said in the first slide, improve with treatment. Third, starting medications, antidepressants, doesn't mean you're on them for life. There's a misconception that you can't come off of them or you need them for life, but a lot of people learn to manage their symptoms over time and can taper medications under professional guidance. And then finally, it's not genetically predetermined whether you will have depression. Although genetics increases the risk, they're not destiny. Life events, trauma, stress play major roles. Going into a little bit more detail about the causes of depression, we know that it's multifactorial. Biological factors like brain chemistry, physical health can make someone more vulnerable to depression. We also know that hormones can make, like postpartum, peripartum, people can be more vulnerable and susceptible to depression. Also in teenagers, there's maybe emergence of depression around menstrual cycles. So I think just as a female provider, I'm always attuned to that. Psychological factors that may make someone more vulnerable is negative thinking patterns, low self-esteem, unhealthy coping skills, early life trauma, and then there's social factors, isolation, lack of social support, COVID, doing Zoom school, poverty, major life changes. Those can all really precipitate depressive episodes and symptoms. Treatment options are vast. I think we'll also talk more about this in the Q&A. There's medication, one of the most common and effective treatments for depression, especially in moderate to severe cases. Antidepressants are the first line treatment, and they help rebalance brain chemicals like serotonin and norepinephrine. About 60 to 70% of people experience significant improvement with medication. The results aren't instant, and it might take 4 to 6 weeks to get better on a lot of the medications. Next, there's therapy, especially CBT is an evidence-based treatment for depression where it helps people reframe negative thinking patterns and develop healthy coping skills. And really, we know that therapy and meds combined is the most effective treatment for depression. Other treatments that people don't think of at first is that lifestyle changes and support from the community and friends is really important. Like Jessica said, not being alone, even though there's this instinct and desire to be alone, is really important in the healing process. Connection with family, friends, peer groups can really reduce isolation. And one thing I like to know too is that exercise actually has antidepressant effects. So I always encourage my patients, it doesn't have to be strenuous exercise, walking, any type of kind of getting your body moving is helpful for depression symptoms. And then finally, for people who don't respond to standard treatment, there's more novel and innovative treatments. And also there's interventional treatments like TMS, ECT. And we can talk more about some of the new developments in depression treatment. We know that there's a lot of hype around psychedelics, ketamine. I'm happy to answer questions if people have. Specifically, ketamine is a new treatment, was used as an anesthetic, but now it's helping people with severe long-lasting depression feel rapid relief within hours. There's an IV formulation that's given in specialized clinics, and then there's a nasal spray that's FDA approved for treatment-resistant depression. Again, this is used alongside another medication usually and under medical supervision. Ketamine is different than psychedelics. Psychedelics work on serotonin receptors, just like standard depression treatments. And we know that these can kind of reset brain networks involved in mood and self-perception. They are actually experimental and not FDA approved, even though there's a lot of maybe articles out there about using it, it's still not FDA approved. And I always advise caution around treatments that are kind of that new. And then there's neuromodulation techniques. There's new types of TMS, deep brain stimulation, vagus nerve stimulation for people who can't tolerate meds or aren't responding to meds. I always encourage people to look at apps. There's virtual reality apps, meditation apps that can help people experiencing depression symptoms. Last, I'll just show the slide about some resources. These are more general resources nationally that I recommend, and I know there's some specific to the Jewish community. So I always encourage people to look at their local federation to see if there's any resources that their federations offer. Yeah, so 988 is one really important one to remember because that is a confidential support line for people in crisis or distress, and it's national. So it's easy to remember. 988 is the suicide helpline. That is my presentation for today, and thank you all for listening. Now I'm happy to answer questions with Jessica. Oh, Dr. Mermelstein, we can't hear you, sorry.
There we go. There we go. As the audience can, as we can all hear, depression is a very complicated, complex situation. Many people start by being anxious and then become depressed. Some people get triggered by life events. Sometimes we don't even know how depression starts or why depression starts. The good news is that it is eminently treatable. It is eminently treatable. Sometimes it's a single episode. Sometimes it's multiple episodes. Sometimes it's a lifelong chronic condition, but like any other chronic condition, it doesn't mean that every day or every week or every experience, doesn't mean that you're stuck in that place. And as Jessica is the very courageous, thank you for sharing again, expert on this, that learning how to modulate and learning how to moderate and learning how to treat it and learning how to identify the triggers has made a world of difference to her and has allowed her to treat her chronic depression the same way people treat other chronic illnesses. So with that, I'd like to turn it over to any Q&A questions, and we can begin okay. Question 1, do you believe that there's really no reason that the depression occurs? For example, infertility, or if someone has been searching to find a spouse and they're just not going to go away until they have that partner, no matter how much they try. Dr. Shayani talked about the difference between sadness and grief and depression. Many things in life make us sad. Some things in life lead us to be grieving. Every experience in life triggers a clinical depression. And so, yes, if you are struggling with infertility, and especially with all the changes that infertility treatment can lead, and all the hormones and all the medications and everything else, and the uncertainty and the sadness, that can all raise your risk, but it doesn't necessarily mean that someone is going to be depressed. It's something to look out for. It's something to be cautious about. It's something to be aware of. About 20% of patients in any medical setting are clinically depressed. Why that 20% versus 80%, I'm not sure, but it is, but 20% across the board in rheumatology clinics and OB clinics and cancer clinics and, cardiac clinics, about 20% of patients in any medical setting have a clinical depression. Anybody else want to?
Yeah, I'm happy to jump in. Can you just restate the original question? I think I got.
Do you believe there's no reason for the depression to occur? For example, infertility, or someone's been searching to find a spouse, and it's just not going to go away until they have that child to find that partner.
I see it now. Yeah. So I always think of depression as like kind of a threshold, right? So we might be predisposed to depression, right? But then like life stressors kind of like put us over the edge. And I do think that like when life stressors are resolved, like our ability to cope with the depression may match where our depression is, if that makes sense. So I think that sometimes there is a trigger, is what I call it in clinic, where something triggers the depression, and when that trigger gets resolved, like the depression can get better. But I do think that when there is a gap in like the coping skills needed to handle a situation, that's where depression kind of comes out strongest. And I don't think there's always like an objective reason, like, oh, you should be depressed if you're in this situation, or obviously, because there are people with infertility who don't get so depressed, right? So there are stressors, but there are also other factors that play into it. So you can treat depression by treating a stressor, but not always, if that makes sense.
Okay. Okay. Please comment about recent issue of cognitive changes on long-term SSRI. Dr. Shayani, this is for you.
Sure, yeah. So I don't know if there was like a specific study about this. It's not a side effect specifically of SSRIs that I encounter frequently in my practice. I can imagine with older adults, this could be an issue because we see with any psychoactive medication in older adults in the geriatric population, there is a risk of cognitive changes on meds. So I always start very low with medications in that population and go slow to reduce any risk of side effects leading to cognitive change. I will say that what we do see in a lot of our medications too is like, while there may be a cognitive change while you're on the medication, usually you come off it and the side effect will go away. So I'm not sure if there's a specific study that is being referred to, but those are some of my kind of general principles about side effects.
Okay. So I also wanted to, the other thing that's complicated, depression is complicated. And so in patients, people that are complicated, people in the geriatric population have many reasons why they have cognitive changes. Depression itself can cause what's called pseudodementia. Some of those symptoms about not being able to focus, not being able to have energy, not being able to be motivated, they can appear. Depression itself can make people appear like they're demented, like they're developing dementia. And technically, when the depression gets treated, those symptoms disappear. Increasingly, it seems that those symptoms don't always disappear totally. So it's really hard to tell whether it's SSRI related, it's medication related, or medically related. I don't want to. So I just want to point out that one of the things we have is that people come. When we see patients, we say, in your own life, never mind patients. We all know we all bring to every situation who we are. Bring to situation the totality of who we are. All our life pieces, where we come from, who we are, how we're raised. It includes all parts of our body, all our nervous system, and all those things that cause depression are also part of us. Our brain doesn't know that, okay, this is a little depression cue, and this is the other part of the cue. And as Jessica had said, that when she is at her most depressed, or when she's having panic attacks, that then leads to depression, which is not an uncommon story, that her body felt like it was shutting down. So there's an interaction, very, very strong interaction between a body and mind, and between all parts of the body and the central nervous system. And so sometimes what we think is causative, I don't know that we can always identify what the SSRI did and versus what the person's mental health is. There was a question, though, about access to care during reproductive years, about access to care. Jessica, do you want to talk about what your experience was in terms of accessing care?
It's a really hard question. And I think it's a problem just from a personal experience. It's something because I run a mental health organization that I deal with all the time, not only in my own personal life, but in the amount of people that reach out to me. Mental health care at least proper mental health care is very, very expensive. There are clinics within our communities that, take insurance such as Medicaid. I can only share from my own personal experience. I can't share as, a whole population. But when my mental health started spiraling, I really needed professionals that were skilled and had I believe that a lot of the treatment is not only about the skill, but it's about the connection between the client and the clinician. And for me, when I was at my worst, I needed a treatment called DBT, which is dialectical behavioral therapy. And it includes you're with an individual therapist and you're in group therapy once a week, and you also have access to skills coaching. So while you're learning the skills to manage your anxiety and depression, if you're practicing them and you need a little help, you have access to that clinician. And it's expensive. And I had to turn to people in my community to raise money for therapy. So I don't know if that's your question. This is one of the hardest things, at least with my organization. The reason why we're trying to put support groups into place is because so many people cannot afford the treatment they need. And I can't change the system. I wish I could. And I think it's a problem so many of us are up against. It's not easy.
It's not easy, and I'm sorry. I'm sorry that if someone's already struggling with feeling awful and worried about their future and can't sort of make sense of where they're going, needing to add to this stress is, I would tell you, inexcusable. However, the good news is that there is treatments available, and in the Frum community and the Jewish community, there is availability. Not perfect. It's not perfect. It's actually not perfect across all medical care. With insurance, without insurance, and the more specialized treatment you need, the harder it is to find. However, it is, your experience, your experience sounds like it was excruciating, but I just want to reassure people in the audience that treatment is available. It is successful, and please pursue it and try to find it.
And I just want to also add that from my personal perspective, therapy is amazing. Medication is amazing. I'm in both. And I think for anybody that's, trying to manage or is being challenged with mental illness, really finding a community of support is as important, if not more important sometimes, because that feeling of isolation and loneliness is not something that either medication or therapy fixes. And that loneliness and isolation is often, at least for me, was what led me down the very dangerous paths. So I think finding a community is just as important to be put into a treatment plan as therapy and medication.
Absolutely. Thank God the stigma of psychiatric care, the stigma of needing care, the ability to identify, to recognize that maybe something is not right, we've gotten much better at it. We've gotten much better at it. We've also gotten better about asking. It used to be that we didn't ask. And so now when you go to see the internist, when you go to the OB, when you have the internist, there are many opportunities where people will ask you how you're doing. And I'm going to ask the audience to please be honest and tell somebody. They're asking They're asking because they want to know, and they're asking because there's options for treatment. Okay. So next question. I personally thrive in life, but as I become an older single in the frum community, my depression gets worse after each birthday. Dr. Shayani?
Yeah. Yeah, so I think this is similar to the question before about like stressors and can you really fix depression if you're not treating the acute or the thing that's most stressful, right? And so I think the guidance I would give in this instance is similar to what Jessica said, is finding a community, which I'm sure maybe this has already been done by the person who asked the question. I don't want to give advice they already know, but finding a community that can give some support in those situations, going through the same thing, really finding relatable things. I think this is a separate topic, but like shidduchim and the pressure to find one by a certain age is a very stressful topic in general. And I think also not being kind of also asking for support around that is important too, right? Like not bottling it up and, showing that you're fine, but really asking for help with that also.
So there are a couple of questions that have come up that I really want to make sure that we have time for, if that's okay. One is the question of ketamine. You mentioned ketamine, Dr. Shayani, very quickly, and you mentioned microdosing, and especially in the frum community, it's a very, very common question. It's a very, very common thing. In my clinical experience, ketamine, if you respond, you can respond very, very quickly, but it doesn't necessarily last, and it has an addictive quality to it. Ketamine itself is addictive. Recent research suggests that maybe it's not as effective for most people over time. There's a new study that was just published about 3 weeks ago that talked about that thought about having to review the current the studies on which it was approved to think about it. Nasal ketamine, which was originally only approved as a secondary augmentation, because really when you do medication, you sometimes do one treatment. If someone has a partial response, you increase the treatment, you add things, you try to get the best response possible. Now there's approval for nasal ketamine without the primary antidepressant. But as Dr. Shayani said, it has to be done only in medical supervision. There are side effects, there are risks. And from my side, I'm not sure that we know exactly what it's going to look like over time. Dr. Shayani, your time.
Yeah. So I think when we talk about ketamine and microdosing, there's two separate things to think about. One is that ketamine is different than psychedelics, right? That have been microdosed, are not FDA approved, are hallucinogenic medications that work on serotonin receptors. We know ketamine works on a different pathway. It's a dissociative anesthetic. It works on the glutamate system. So that doesn't mean that much to most people, but it works differently than LSD, MDMA, street drugs. However, ketamine has become a street drug. We know that IV ketamine has high potential and risk for overdose. And when we think about microdosing, there's also a high risk of overdose because people take small amounts slowly and they don't realize that it's building up in their system, and there's a risk that the dose is too high. There's no clinical evidence to support microdosing, and there's really no evidence to support ketamine use outside of a clinical setting, right? We know that the experience of using ketamine should be monitored and therapeutically based. You should be using it in a setting where there's someone to help process the emotions that come up because they can be intense. We know that afterwards there's cognitive changes. People shouldn't drive after they take it. And there can be also a lot of physical side effects that need to be monitored clinically. So I always caution that when you're using this medication, I know there's a lot of options for where to get it now, but it needs to be done under close medical supervision.
So, what we've been talking about, there were some. Okay, there was a question about ayahuasca and other raises the question about natural about natural. One of the things that always comes up is, what about all those natural things? What about all the supplements? What about non-pharmaceutical agents? And it is, there are lots of things that are natural they're pure in nature, but some of them are toxic and some of them are useful. And I think it's very important to know that just because they're not, exercise is helpful, good health is helpful. There are some supplements that may not be helpful, but they often do not replace, for someone who has clinical depression, do not replace treatment. And treatment, pharmaceutical medications, we know what's in them, we know how much is in them, we can monitor them, which I think is a tremendous advantage. Dr. Shayani?
Yeah. So ayahuasca is a psychedelic. We know that would operate like LSD, kind of any hallucinogens. They've been used for centuries. Now they're emerging as people want to study them. They're not FDA approved, and there's a lot of risks associated with them. So I never actually recommend any of those substances. In terms of natural treatments, we know vitamin D can be helpful as a supplement for treating depression. Low vitamin D can be a cause of depression and can impact mood. So vitamin D supplements helpful. Good to get your levels checked though, because you don't want to be taking too high of a dose than what you need. And you also don't want to underdose if you actually need more vitamin D. So always talking about that. Omega-3 fatty acids can help with cognition. They can have anti-inflammatory effects that help regulate mood. There are a lot of other supplements out there that are marketed as for depression that don't have good evidence. And I think that there's also interactions with standard treatments for depression. So like Dr. Mermelstein said, if you want to use these, I frequently ask patients for a list of supplements they are using, because I need to run it by the pharmacy and make sure there's no interactions in terms of kidneys, livers, the organs that are processing these meds. We don't want them to get overloaded.
So Maimonides is famous for saying that there's the golden path, not too much and not too little. And so a lot of the supplements, a lot of the vitamins, even if they are helpful, we have to make sure that's not too much. So Jessica, there's a question for you, if I may. You were talking about how important the community is, and you're right, it's critical. And sometimes are naturally occurring, sometimes supports are naturally occurring, and sometimes they have to be created. So what do you think, if someone is suffering and struggling from depression or severe anxiety, which then leads to depression, as in your case, what do you think was most helpful? What do you think people can do to help those that are struggling or suffering?
Repeat the last part of the question. What do I think
So what do you think? What did you find most helpful in the support system? And what do you think a family member or friend can and should do to be most helpful? What did you find helpful, and what do you think people can help with?
Okay, so I just want to backtrack a little bit. I spent my 40th birthday in a psychiatric hospital, and it was there that my organization was born, because there was another frum person in the hospital. It's a very, very lonely and isolating illness, and exercise for me was and is still a very big coping skill. And so I started walking the hospital floors. And I saw this woman and I asked her to join me to walk. And it took a few days. She first said no. Second day, she said no. Third day, she started to walk with me. And by the fourth or fifth day, she was in her in her regular clothing, out of her hospital gown. And the turning point for me was an African-American nurse coming up to me and saying, "Bubala, I don't know what you're doing, but keep on doing it." And I was like, I'm in a psych ward, here to get help. What am I doing? And it was like light bulbs started going off. It was like connection, like connecting to somebody else in pain is the way to get through this illness. And there was a question before about somebody who is having a harder time as she gets older and she's still single. And I just want to, bring a point. We have a woman in our support group. Everybody's married. She's an older single in her 50s, never been married. And we can't take away each other's depression, but what we can do is be there to support each other. Like none of us will be able to take away each other's pain. We can't change each other's personal situations, financial, marital, married, not married. We can't do that. But the support that we can give each other is worth more than I can put into words. I think for family members, the first part starts with either you can see that a person is struggling. or you can't see. And if you can't see, it's going to take courage from that person to open up to somebody and say, I'm really having a hard time. And for me, the most helpful thing, and my friends know it, when I start to isolate, don't try to fix the problem. Don't try to make them happy. Don't try to, don't try to fix them. Instead, tell them, I see that you're suffering. I see that you're in pain. I see that you're having a hard time. Validate them and ask them what would be the most helpful for you, because it's different for every person. For one person, it may be a text, I'm thinking about you. For another person, it may be dropping off a bowl of hot soup. For another person, it may be somebody cuddling in their bed with them and giving them hugs. It's so individual and so different for each person, and so important for them to be asked, not just to do, but to ask.
And also to be non-judgmental. You can't
Absolutely.
take away, now can't take away the, you can't take away the pain necessarily, problem, but you also they can't snap out of it. It's
Right.
very important, again, to underscore as we are closing portion of tonight's webinar. It's very important to underscore that depression, there are lots of things that happen in life, sadness, grief, sometimes when you're really not feeling great, but not all of it ends up in clinical depression. Clinical depression, to summarize, is a condition whereby really those feelings and the associated symptoms, sometimes, it's irritability or physical or anxiety or non-functioning or not being able to think straight, or at more severe suicidal wishes, suicidal thoughts, even suicidal behaviors, where all that is, those conditions are like any other medical condition, and they deserve treatment, and they can benefit from treatment if they warrant treatment. Among women, one of the particular things that's very important to know is that Dr. Shayani mentioned it, but a lot of women struggle with depression symptoms that come around any kind of change in hormonal levels, whether it is around your cycle, menstrual cycle, or whether it's postpartum. And some of those women also when it's menopausal. Whenever there's a change in hormonal symptoms. Postpartum depression is different than baby blues, right? Baby blues is sort of but no one sleeps the first couple of weeks they have a baby. It's often very stressful and they need support, but most women who just have, I'm not discounting the importance of baby blues, but who just have baby blues, they're able to manage once their own sense of self in this new situation of having a baby improves. What doesn't improve is if someone has postpartum depression. Postpartum depression can exist and can be present untreated with very severe consequences, even suicidality over time. There are reproductive psychiatrists that are experts at the depression secondary to hormonal changes, even after childbearing years. But so my last comments, well, I'm going to ask everyone, I'm going to Dr. Jessica and Dr. Shayani to give sort of their last 1-minute summary. But Jessica, please tell us what the name of your organization is.
It's called Catch Support.
Okay. Catch, as in CATCH?
CATCH, yeah, it stands for Creating a Team of Courage and Hope.
That's terrific. So what's your last 30-second comment for this audience?
Me?
Yeah, please.
It's really just to let people know, and I know those words, that you are not alone. People do really feel like they're alone, but they can reach out to me, when I don't know if my information is on there. It's info@catchsupport.org is my email. They can reach out anytime, and to not give up hope, to realize that even though they're experiencing pain and possibly, hopelessness, that, like you said, there is treatment out there, there is help out there. They just have to have the courage to ask and find it. And it is an illness that is manageable with the right treatment and skills and support.
Dr. Shayani.
Right, yeah, just building off that, prioritize getting help. I think it's easy to say this might go away on its own. I think we know that the longer you wait, the worse symptoms can get without treatment. So really prioritize getting help, seek help early before symptoms kind of build up. And yeah, everything Jessica said, there are people out there who are going through the same thing, try to figure out how to find them. I always say local federations really have a lot of resources for therapy and meds.
So we as individuals are not one size fits all. We're not all the same. What causes our depression in each one of us, struggles and suffers, is not the same. There are many things that are similar, but they're not exactly the same. What treatment will exactly work and what combinations of treatments will work is also not the same. But thank God there's a tremendous number of options. And not only please get help, please seek help, but don't give up. If the first treatment doesn't work or only works partially, it's not that your depression is not treatable. It's not that you can't feel better, and it's not that you can't do better, as Jessica very bravely and courageously has talked to us about. Please get help. Please seek help. Please get help, and please don't give up. There are people, organizations, professional and communal, that are here for you. Just want to also sort of give a little plug to JOMA. This is one of many of JOMA's webinars. We have several that are coming up. They range in all kinds of topics. We want to welcome you, and please feel free to submit what you think would be helpful, topics that you'd like us to talk about, and we'll be happy to be here both as a resource and as an organization that will continue to provide education in the Jewish community and beyond. So thank you very much.
Thank you so much, Dr.
Thank you.